To round off this session, I'd like to welcome Mark Edwards. Let me just move here to actually talk to us about rehabilitation. And I'm sure you will, Mark, in your presentation, but just I think to explain the concept of it, I guess, in dystonia would be great as well. Thank you.
So thank you very much in the last slot, so I promise I'll be quick. But I was going to talk a little bit about rehabilitation. And rehabilitation is a complicated concept in a way, because we could talk about physical rehabilitation, where you might work with a physiotherapist. We might talk about multidisciplinary rehabilitation, where maybe you're working with a physio, an occupational therapist, a clinical psychologist, a speech and language therapist, a neurologist, a psychiatrist. So rehabilitation covers a huge field, really. And I think it is worthwhile thinking a little bit about dystonia in terms of what's going wrong in the brain, because that might give us some ideas about why rehabilitation might be useful in particular situations. And then sort of following on from that, there may be particular types of dystonia that, because of what's going on in those particular types, might make them particularly suitable for specific types of rehabilitation. And then just a couple of words on the sort of gaps that need filling in terms of services and evidence to make rehabilitation a bit of a reality for people with dystonia. So I'm hoping this video is going to play. So this is a video of the Robot World Cup. So this is a competition run every year for the greatest scientists and engineers around the world, where they designed robots to play football. And as you can see, it's not very good. I think this is actually the World Cup from a couple of years ago, but they're no better now. So he is going to score a goal in this thing. The reason for showing you this video is just about there's no problem with this robot's strength there. What the problem is with control. And that's what dystonia is all about. So dystonia is typically not a problem with power in the body. The muscles are perfectly powerful. What's going wrong is that they're not being controlled in the right way. And so, as these robots point out, movement control is a really complicated thing. It's much, much more complicated than we might assume, first of all. But because dystonia is a problem with control, maybe you could use rehabilitation in terms of relearning to get better control over the system. So as a concept, rehabilitation makes sense for something like dystonia. And then if we think a little bit more about what's going on in the brain in dystonia, so there's this concept that in dystonia, there's a particular problem with a thing called brain plasticity. And so what plasticity is a fundamental feature of the brain and the nervous system. It's what lets us do what we can do. And it's basically the ability of the nervous system to learn things. So it's ability to, when you get a situation, so when you get something happening to you, you can change your response to that. So you can learn how to change it. So, for example, learning to walk is an example of brain plasticity. So just that example shows that brain plasticity is something that's very, very, very active when you're younger, when a child, and it tends to become less active when you get older. But it's still active even when people are in their 70s and 80s. So the idea in dystonia is that, at least in certain types of dystonia, this system goes wrong. So that means that it's sort of overactive. So abnormal connections and associations get made, and people sort of, in a sense, the brain has mislearned how to move. So again, from a theoretical point of view, it makes sense that maybe there might be a way of kicking the system to do something different by relearning. So if we think about, and this point has been made earlier as well, that if you look around this room and if you read papers about dystonia, if you look at websites about dystonia, it's clear that there are many, many different routes by which people develop this thing we call dystonia. So in a sense, there's a movement control problem of dystonia, which is the end result of lots and lots of different brain processes and illnesses. And although some of these illnesses might be similar, it also is logical, and I think it's just the case, that there's probably lots of differences in these mechanisms. So there may be particular types of dystonia where rehabilitation makes the most sense. So I'm just going to go through 3 examples of that. So wanted to talk just a little bit about task-specific dystonia. So in task-specific dystonia, it's a corruption, if you like, of the program for doing a very, very specific movement. So the classic task-specific dystonia is musician's dystonia. So this typically happens in professional musicians, happens in about 1% of professional musicians. They're people who have had thousands and thousands of hours of practice of a particular type of movement, and then suddenly that movement goes wrong and they can't produce it anymore. But actually, if they were to use their hand for brushing their hair or using a knife and fork or pointing at something, it would be completely normal. It's just in that particular task. And you can see it in other situations, for example, in professional sport, like in golf, for example. So this seems like a very clear example of something where things have got mislearned. So somebody's repetitively practiced a highly skilled movement, and suddenly it's got out of the way it should be. And so that is a situation where there's actually quite a lot of evidence that specific types of retraining can be useful, and particularly a thing called sensory motor retraining, where you're trying to retrain the sensation side of things. So how do you feel things and discriminate things in the hands, as well as how the hands are moving. So there's not an enormous amount of published evidence, but there's programs worldwide where people, mainly professional musicians with dystonia, have this particular type of retraining therapy, often accompanied by using botulinum toxin and other things as well. And for some people, it can be helpful. But you can see that this is a very, very specific type of dystonia, which may not be relevant to lots and lots of other more common forms of dystonia. I want to talk next about functional dystonia. So functional neurological disorders are a very, very common, genuine way to get neurological symptoms. And describing the mechanism of it is a bit tricky, but one way of thinking about it is that in functional dystonia, the wiring of the whole system is completely normal. So if you were to go into the brain and you were to test it electrically or with a scan, all of the wiring is absolutely fine. And people are trying as hard as they can to get their bodies to work for them. But for some reason, they're not able to access their bodies in a normal way. So when they tell their body to do something, it's not working, even though you can often show on examination that it can work. So in that situation, again, rehabilitation makes a lot of sense. I was just going to show you a video of this chap who's got lots of different problems, but you can see he's got an abnormal posture of his foot. And he's just been asked to stand up. And you can see that he's doing that in a particular way, and it's not easy at all. It's very, very difficult. So in the second video I'm about to show you is from the same session where he's worked with a physiotherapist who's very experienced in helping people with functional dystonia, other functional movement problems, and is showing him how to change that. So in this next video, he's in front of a full-length mirror, so attention is being focused outwards onto controlling the body in the mirror. The physiotherapist has positioned him in the right way. You see he's managed to get that posture of the foot down on the floor, and now he's going to be asked to stand up again. And you can see that even though it's not perfect, it's a lot better than it was. So this is an example about, again, in a specific type of dystonia with specific types of physiotherapy, you can produce really quite dramatic results in some people. So the last example, so we talked about task-specific, talked about functional dystonia, just wanted to talk about cervical dystonia. So one of the ideas that's become a bit more current about what the mechanism, so what's going on in the brain in people with cervical dystonia, is that there's a problem with what's called a neural integrator. And I think that picture there with the puzzle piece is a good example of what a neural integrator might be. So it's a bit of the brain that's putting together signals from lots and lots of different sensors, so from vision, from your balance organs, from feeling of position sense, from sensation in the skin. And in cervical dystonia, one idea is that there's something that goes wrong with this sort of integrator. And so with respect to things like where your balance organs are telling you which way your head is pointed, for example, that this information is not getting in the right way. And therefore, the whole system is set wrongly. So instead of when you're asking your body to point your head forwards, it's pointed off to the side because this information is not getting into the brain correctly. So that's another example where, in a much more theoretical way, maybe you could use rehabilitation as a way of trying to reset this system. Because if it's just sort of offset by some way, maybe you could stimulate the system, maybe you could give the person different feedback in rehabilitation to help correct this. And that's one of the things that's done and popularised in physiotherapy for cervical dystonia. But when we come to thinking about this in real life, in practice, although there's quite a lot of reports in the literature about, oh, this sort of physiotherapy might help a few people, it's often on a very, very small scale. And so there's not a lot of evidence to support, for example, your health authority saying, okay, we're going to invest lots of money in physiotherapy and dystonia, because it's hard to make that case, even though all of us would think that that's probably going to be a useful thing to do. There's been a recent large-scale randomized study in the Netherlands where people with cervical dystonia were randomized. That's on a flip of a coin. They were sent to have standard physiotherapy or a specific type of physiotherapy based on work by Bleton about how physiotherapy might help somebody with cervical dystonia. And then they followed people up. And what was found at the end of that is that actually everybody improved, actually improved quite a lot, but there wasn't really a big advantage for the specialist physiotherapy. But if you read the paper, the people in the standard physiotherapy group got physiotherapy every single week. So it was a huge amount of physiotherapy input. Okay, so that's not really standard physiotherapy from an NHS point of view. So I think the point of this shows that actually with physiotherapy in people with cervical dystonia, there is some evidence that it can be useful. But what we need to know is more about how to make it even more effective and how to select the right people for the right kind of treatment. So just on the last slide, there is a rationale, there is a logic to why rehabilitation might make sense for people with dystonia because of what we know about how the brain goes wrong. And there's particular types of dystonia where it might be most useful and where it's most developed. But sort of following on from what Marjan and Catherine were saying in particular, dystonia is a multifaceted illness. It affects all parts of people's lives. And so the idea that just sticking in a bit of physiotherapy is going to make everything better is not correct. So trying to combine all of these things together. So rehabilitation can be something which goes beyond physical treatment towards psychological treatment, towards how to help people function in day-to-day life, to help people keep in work or keep in education. And so if you open up rehabilitation that way, then it becomes a very relevant thing for people with dystonia. Thanks very much.
I want to thank you, Mark, for bringing that to a close in terms of there's a hashtag about everybody, and it is about everybody, isn't it? About absolutely every discipline and everybody out here as well, isn't it? As well. So thank you for that. Do we have usual format? You are just pre-coffee, actually, just pre-tea, but please don't let that stop you if you have any questions at all. Yes, straight away. If we can bring the microphone down here to the front row, please. Yeah.
Okay. This is a question for Mark and your predecessor as well. In fact, a few people have talked about this. So we agree that that bringing in the psychological, psychiatric and the motor specialisms together is what we need to be able to treat the whole person, and that there's an interrelationship between those different factors. But how do we implement that in our siloed healthcare systems? And I'm thinking particularly of my own situation where I have a child who has disability. He sits within the physical disability service. We're quite lucky where we are. We have some mental health services within that service, but not everyone has that. Now, there are lots of parents and others here who are stuck with a child who's in one service or another and need to have an integrated approach. How can we address that and make that happen?
So it's a really good question, and we need to do it by just making it different, really. There is a move nationwide and worldwide to try and stop this completely ridiculous split between physical and mental health, both in terms of services and also in terms of value and stigma and so on. So there are good examples, particularly within neurorehabilitation, I think, where that is happening. because neurorehabilitation, because it's something that's affecting the brain, quite commonly affects both brain and mind. And so neurorehabilitation services, for example, after traumatic brain injury, quite commonly try and put together both physical and mental health professionals as part of rehabilitation. And that's one way to sort of start. But it is very, very difficult. And because the services often don't really talk to each other, it's very, very difficult to get that integrated care. But there are areas where it's happened. MS care is another example where it's not brilliant, but it's better than most in terms of sort of pushing together both physical and mental health provision for people in a joined-up service.
Perhaps we could also push for people in physical services to start to recruit some people with mental health skills within their physical service.
Yeah.
As a start, it'd be better to integrate, but at least we can start to integrate the expertise wherever we might happen to be. I
agree, and again, there are some examples. It's all very slow and it's very patchy, but there are examples of community services, for example, so where Francesca and I work at St George's in the Wandsworth community therapy team, the mental health and the physical health people have got together, and so there are psychologists who work in the neurorehabilitation service in the community.
This isn't really trouble.
Yeah.
The main trouble is that you get funded if you have data. And the trouble in physiotherapy is that pursuing clinical trial on the way that you do with the drug, with the placebo, is not working with physiotherapy. So even when in Netherlands they did this clinical trial, they could not make one therapy better than the others. And it was extremely difficult. The protocol is difficult. And if you don't have strong data, you don't get the money. So, I mean, I can see Hortensia moving. And it's true that the working she's doing is amazing, because if you're trying to put some science underneath, everybody knows that it works.
But I think this is why we need to change the way we do clinical trials, particularly on new interventions where we don't have any feasibility, any proof of concept. This is where single case experimental design, N of 1 trials, personalized medicine, this is where we probably need to go. I'm really interested about what is standard physiotherapy, even once a week. What is it? You know, does your band 5 give you the same as somebody that has 30 years of experience? You know, what are we doing? Did they do fidelity check? There's so many things that I think we'll only be able to start answering those questions with good methodologies. And I think NIHR, for example, are funding some of those studies. But with dystonia being such a heterogeneous population, then we've got that issue as well. And the N of 1 will help us to answer some of those questions.
I agree, and there was this fantastic review of all physiotherapy in dystonia, and at the end they conclude, they say what we need is still a clinical case study, and to understand what we should do and how we can show it, but it's, as you say, not the classical protocol of clinical trial which is going to work, so things need to change.
Hi.
Okay, one more and then we'll close. Okay.
I was very interested actually in what you were saying about the cognitive thing. You know, actually wanting to do something and not being able to physically do it. A few years ago, I mean, my writing has never been good. My handwriting has always been really awful, and I've had to have lines. You know, I couldn't do it on blank paper. Now, I found about a year and a half ago or whatever, suddenly I can write better than I could before, which I found quite fascinating. I don't know why, but that's, so when you were talking about, I just found that very interesting, that things can change like that.
So I think they can, and I think in general, if people have a long-term problem where movement is not working correctly, people naturally develop strategies, either strategies that they really think about and put in place, or that just emerge naturally, if you like, as an adaptation. But quite often, you see this a lot in people with cervical dystonia, quite often those adaptations end up being unhelpful, unwittingly unhelpful. So for example, postural adjustments, tensing of the shoulders, for example, to get more, so in people who have a bit of head tremor, you stiffen up the whole body, that drives pain, for example. And so having somebody, typically a good physiotherapist, to unpick all of that can sometimes lead to people being in a better situation. Investing a lot of attention into movement, sort of really controlling it, tends to make movement worse in general. But often people are doing that because it's a strategy, but sometimes to help, but sometimes there are better strategies as well. So that's where, yeah.
So I want to thank our panel, actually. What we set out to do, it was a tall order, wasn't it? Get you to talk in 10 minutes, sit down and then talk to the crowd, to everybody and between yourselves. That was a really tall order, and thank you for going with it. I mean, Dr. Marin, you were right when you actually said, let's give the people in the delegates a chance to talk to you as experts before we began this. You were absolutely right. And I hope we did manage to actually do that, even in a snapshot, really, whilst you all sat here. And I'm glad, actually, we were beginning to have some dialogue between you all. It's just sad that you couldn't carry that on the stage, because you could see that developing as well. But thank you so much to you all. Thank you for participating.